It's setting up. Okay, you guys are good to go.
Good afternoon, Heartland Health Centers family. I am so glad that y'all have tuned in today. We have an amazing discussion with our very own Dr. Bridget Buyea. She is a very special person in my heart. I worked with her for almost 2 years at our Wilson location, at our Uptown location that is located on Wilson and Hazel. And she is a joy and pleasure to work with and have a lot of information. And I'm excited for her to be here today to educate us about endometriosis. So, Dr. Bridget Buyea, can you just take a little bit of your time just to kind of let the people know how amazing you are?
Okay. Well, I want to wish everyone a happy Endometriosis Awareness Month. So it's a particularly fitting topic to be talking about in March. And like Gina said, my name is Dr. Buyea. I am the OB-GYN that works over at Heartland Health Centers. So I've been here for 4.5 years, almost 5 now. I came here straight out of my training program, which was also in Chicago. And yeah, I see anybody at the clinics who need help with obstetrics, with prenatal care, and then with gynecology too. So any issues with your pelvic organs, you should come and see me. So so yeah, that's who I am. That's what I do, and I'm excited to help people learn a little bit more about this topic, because I think people have heard the name but maybe not really know what it is.
Mm-hmm. Thank you so much for the introduction, Dr. Buyea. So we have some questions that are pre-prepared, but if y'all out there have any additional questions, please drop them in the box and we're going to get Dr. Buyea to answer any and all questions. So to start us off, Dr. Buyea, what is endometriosis?
That is a really actually more complicated question than it should be. Really, to make it as simple as possible, it's basically your endometrial tissue, which is that menstrual tissue that you release, most women release every month. Instead of it going out the vagina, we find it in places it's not supposed to be. So endometriosis is when you have that particular type of tissue inside your abdomen. So on your ovaries and your tubes, just inside the open space of the abdomen, even on your bladder or your rectum. So as you can tell, it's not a good thing to have.
Absolutely.
But that's the most basic explanation. And so that tissue is still alive and it's still doing things. And that's where it becomes a problem.
Absolutely. So who is at risk?
I think one of the biggest issues that we're facing right now with endometriosis is that we don't know that much about it in terms of why, like what the cause is. And so therefore, we don't have great information on what the risk for endometriosis is. We think there's a genetic component because it does tend to run in families. If you have a first degree relative, so that's like a mom or dad, or not a dad, a mom or a sister, or someone who has female organs and they have endometriosis, your risk of having it is about 10 times higher, but it's not guaranteed. So as far as we know, that's the only risk that we can really point to. We don't think that there's any like racial specifications to getting this. It sort of gives it to everybody equally, unfortunately. And it affects around 1 in 10 women, depending on the research that you read. It says it's 6% to 10% of women who menstruate have endometriosis, which is actually pretty shocking when you think of it. Like if you've got
Absolutely
people with a uterus, then one of those people probably has endometriosis, and that's only recently being recognized. So despite the fact that in our literature, we see the first documentation of endometriosis being from 300 years ago, we don't really know as much as we should for how long we've known about it.
Okay, that is a very good point. And so I guess I would beg to ask, are they trying to learn more about it now?
Yes.
Okay.
So I think that like that sort of, I guess that goes back to the what is endometriosis, and which I should have maybe gotten into more, is that we don't really know how people get it. We just have theories. And so it is a focus of research now because we want to know how, so we can have better treatments, which we can get to into more detail later because we don't have awesome treatments for this. But the most likely theory, the one that makes the most sense is that, you know, where does this tissue come from? Is it coming from the uterus? And what we think is happening is it's called like retrograde menstruation or reflux menstruation, meaning, you know, your menstrual tissue is in the uterus, and when you don't get pregnant, there should be a stimulus to release that menstrual tissue and blood out the cervix, through the vagina, into the world. What we know happens in actually 90% of women is that a little bit of that tissue, instead of going down, goes to the sides, out the tubes. And the tubes end in the abdomen. And so what we think happens is that little bit of tissue that's been refluxed out the tubes, wherever it lands, it becomes an endometrial implant. Now, what we can't explain is why, if this happens to 90% of people with menstruation, why is it that only 10% of the people actually have endometriosis? And that's not an answer that we have. We have, again, theories for why it happens, but it's really just that the most simple way that I think about it is that instead of the body recognizing it as something to get rid of, it turns into it supports it. It doesn't get rid of it. And so it implants and then causes an incredible amount of inflammation and pain and all of those things that we're going to talk about in terms of, you know, what are the symptoms of endometriosis and stuff like that. So,
and yeah, so that's a great segue. So don't keep talking because, you know, I have it all prepared. So what are the symptoms, Dr. Buyea?
So, like I said, like we talked about before, 1 in 10 women have endometriosis. We know based on research. But what we don't know, we also know is that not all women have symptoms of endometriosis.
Wow.
So you have it with no symptoms, and it doesn't matter how bad you have it, like how many of those implants you have, to dictate how bad your symptoms are. So they don't correlate. So you could have microscopic endometriosis and have really bad symptoms, or you could have lots of endometrial implants, lots of scarring, and have 0 symptoms. So that means that the symptoms have a wide range from asymptomatic to most common. The first presenting symptom is just super painful periods, like out of proportion to what would be normal for other people to have for periods. And then it progresses to pain before periods and during periods. And then if it continues to progress, it just means that you just have menstrual cramps and pains like all the time. Another symptom would be that can progress to is like what we call dyspareunia, which is a fancy word for pain during sex. So penetrative sex, hitting the inside of your abdomen becomes painful because of these implants that are inflamed and you're just like hitting them. So those are the most common symptoms. Some other things that can happen is your period can be heavier than the average period. It can be more irregular. And a progressive symptom that we also found associated, or an associated issue, is that, which we're also going to address later, is infertility is also related to endometriosis, which we can get into a little bit more later. But really, generally speaking, the most like a patient walks into my office and the most common symptom that I would hear is like pain, you know, like my periods are terrible. I miss school because my periods hurt so much, or I miss work. Like I'm in so much pain, or right before the period. And so that's usually the first marker that we see where it's like, we should do something about this. This is not normal. This is not like just something that you should deal with. Like I said in the past, which I think sort of feeds into why endometriosis isn't really known that much about, because for a long time it was just like, you need to be tougher, you know, deal with this. It's not that big of a deal when all women menstruate, or, you know, but in reality, it's people have different experiences. And so Pain is the biggest one, but it's a spectrum.
No, absolutely. But see, I'm more concerned about the women who don't have symptoms. So if they don't have symptoms, is there a way to actually know?
So the reason we know that people have endometriosis without symptoms is because they get diagnosed, because it's actually like they have a different surgery for a different reason, and then when they look in the pelvis, they can see the endometriosis, and so or they're getting a surgery for something else, and they're like, oh, you have endometriosis. So
Mhm.
generally speaking, it's not dangerous to your life, but it's still something that we want to be able to manage.
Absolutely. Thank you for answering that extra question.
Yeah.
How do I manage my endometriosis symptoms? Any tips?
Yeah, for sure. So it depends. Like I said, it's a spectrum. So it depends on how bad the symptoms are. If you Google this, the answer that you're first going to get is the same recommendations for anybody who has menstrual cramps, which is appropriate. So like resting, heating pads, warm baths, whatever, those things. But those don't get to a point where it's not super effective. And so the real treatments, the gold standard first line treatments for endometriosis is first to start with something called NSAIDs. Those are non-steroidal anti-inflammatory medications, which is a fancy word for things like ibuprofen or Motrin or naproxen, things like that, because they're anti-inflammatory. And the reason endometriosis is so painful is because it's causing inflammation, we think. And so that's a simple first line management. So you're not treating it, you're not making it go away, you're not making it less. You're just sort of dealing with the cause of you're dealing with the pain of the endometriosis. The next level would be to manage hormones, because we have found that there is some hormonal component to endometriosis sort of being stimulated. So when you get when you have endometriosis, your body is every month goes through a cycle of hormones of increasing and decreasing to stimulate your uterus to make that menstrual tissue. So if you get pregnant, you have like a healthy lining to support a pregnancy. Well, that same stimulation is also going to all these little endometrial implants. And so that's why you get these like cyclic pains in your belly that's not necessarily just in your uterus. So by calming that stimulation down to the uterus, you're also calming the stimulation down to the other implants, which is why hormonal management is the first line treatment for endometriosis. So something that, the first thing we go to is just birth control pills. So birth control pills have so many more uses than just, people are just taking them so that they can have sex and not get pregnant. That's not, that's a very simplified explanation for birth control pills. They can do so much more and really improve quality of life for some people. And so that's sort of for me, like you're coming to see me and you need management. Those are the first two things that I'm going to try and get for you. Now,
Got it.
there's also alternative treatments that's not really so much in my repertoire, is not a specialty of mine, but they exist. There's a little bit of research to show that they can be effective. It's not the best research. It's not the most voluminous research, but it doesn't hurt to try these things. And I would encourage patients to go and seek out like practitioners who know more about it. But things like turmeric at high doses, the what's it called? I had to write it down. That's what I'm looking at right now. The curcumin in turmeric is an anti-inflammatory herb, spice, not exactly sure what the right name for that is. And so that, that can help. Chamomile, they said peppermint, lavender oil, massage, like the first three I just mentioned are all anti-inflammatory. And so it makes sense that it would help to some degree symptoms of endometriosis, because they bring inflammation down, and inflammation is what we think is what causes the pain of endometriosis. So those are some, non necessarily like Western medicine things that you could try that wouldn't hurt anything. But if those don't work or you need more intervention, then the first step would be, coming to see me and talking about those options. There's more than just there's, you know, just like treatment, symptoms are a spectrum, treatment's a spectrum too. So first step is the ibuprofen or something like that, an NSAID, and then you can try birth control pills, and then we move down the line. But if I remember correctly, we're going to get to that in a minute. So
Fair enough. So what are the potential side effects of medication that is used to actually treat it?
Yeah, so it depends on the medicine, but
Mhm.
you know, generally speaking, like I mentioned before, the ibuprofen and the NSAIDs, not too bad. They can, if you do them long term, you can get like stomach ulcers and other things, but generally speaking, if you're just taking it on a limited basis, then there's not huge side effects to the NSAID use because it's intermittent. If you're moved on to hormonal management, it really depends on the individual. And they're the same side effects that you would get if you started birth control. So and they're different for every person. So as a blanket statement, when you start a birth control pill, we say you could have nausea, fatigue, so upset stomach, or tiredness. You can have weight loss, weight gain, change in your acne, increase or decrease, you know. And so all those things could also happen with endometriosis. On the plus side, it should really decrease the heaviness of your periods, the length of periods, and the cramping. Unfortunately, when you talk about birth control or hormonal management, which inherently is birth control, except for one other new option, you sort of have to pick the side effects that you want to deal with because we don't have anything that's perfect. And so I encourage patients, like, just because maybe one birth control pill that you tried for your endometriosis was not good because of a particular side effect, it doesn't mean that all birth pills are bad. It's just that that particular formulation wasn't good. And I would say to consider trying a different formulation because there's an estrogen and a progesterone in most birth control pills, but there's slightly different estrogens and progesterone. So you keep track of the ones you try. And then if they don't work, make sure you know what it was that wasn't working for you. And it doesn't have to be necessarily like, you know, it worked for my pain and my bleeding, but I had headaches all the time. That's really helpful information for us to pick the next one if you want to try something different.
Absolutely.
There's also a fancy new drug that's out specifically made for endometriosis. That's called Orlissa. It's been out for about 2 years now, and it works a little bit differently. It's also a hormone, but instead of being a hormone like a birth control pill, which is estrogen and progesterone, so that works like at the ovarian level, this is a hormone that starts a little bit higher in the cascade of hormones that control your menstruation, your menstrual cycle. And so this works at the level of GnRH, which is a brain level hormone. And it has been shown to really, really help people in terms of their pain and their the pain before periods, during periods, and even pain while having sex. It's not birth control, so you can still get pregnant by taking it. And it has its own array of side effects where you can see some change in your liver function. You can sometimes get a little bit of menopause symptoms because the whole goal is to calm down that menstrual cycle so you're not stimulating your endometriosis. And so that's not necessarily first line, but it is another option that we talk about, you know, pros and cons. And so it's a very individualized approach to figure out what the best medication treatment is. And again, nothing unfortunately is perfect.
Absolutely. No, that makes a lot of sense. You kind of talked about this, but can you share a typical treatment plan for a patient who has it?
Yeah, I think that the first step is diagnosing it. So unfortunately, if I recently read a paper, it's a little bit old, it's like from 10 years ago, but 10 years ago, it said the average amount of time from onset of symptoms of endometriosis to diagnosis is almost 7 years, which is wild.
Wow.
I have patients like that. I actually just saw a lady who I treated, who she didn't get the diagnosis until she saw me. And at that point, she was already in her 40s. And so she lived like almost her whole, you know, menstrual cycle life with misdiagnosis. So it's something that I read somewhere else that you have to see an average of 4 doctors before you get this diagnosis of endometriosis. And there's a couple different reasons of it. The way to definitively the only way to definitively diagnose endometriosis is by doing surgery to see the actual implants in your body, because they're not on the outside, right? They're inside. And so you get a biopsy, you confirm the biopsy, and then you have this diagnosis. That being said, you don't need a biopsy confirmed diagnosis of endometriosis to be treated for endometriosis, because your symptoms are what we're trying to treat, and the management for those symptoms, whether you have endometriosis or not, are pretty similar. So if you come to me with the statement of like, my periods are super painful, I'm missing school or work, like they're really, really bad, and they have been bad for forever, they're always like this, I try taking ibuprofen, sometimes it helps, sometimes it doesn't, that's when we should start getting on this treatment plan. So the first thing to try, especially if we don't have a definitive diagnosis of endometriosis, is to take some ibuprofen regularly before the pain starts, to try and prevent that inflammation from happening and prevent some of that pain. And if it works for you, then great. The next step, like we talked about, is to try some birth control pills or any type of birth control that has hormone in it, because our goal again is to just calm down that menstrual cycle so you don't get that stimulation to the uterus, to the endometrial implants that are not in your uterus, sorry. And so some people get a lot of benefit from doing like depot injections, or I talked about the birth control pill, or even like the patch or the ring, or the IUD has also been shown. The Mirena IUD or the Liletta, anything that's a hormonal IUD, has been shown to be helpful because they all calm down that menstrual cycle. They all, again, have their own set of side effects. And so a lot of patients, you know, we'll just run through them until we find one that's like gonna work for you. And even if we do all of that, sometimes it's not enough. Maybe you find one that's working well enough for you, but your pain is coming back or your pain is worse. And so some patients start like that. Other patients come to me with pain, and we always do an ultrasound to look at the inside. You can't see most of these implants with an ultrasound or even an MRI because they're small. They're like very little. But sometimes you can get something called an endometrioma from endometriosis, which is where there's an implant that's landed on the ovary somehow, and then it's been stimulated and it's turned into a cyst. That's called an endometrioma. Those are also very painful, and the treatment for that is removal, especially if they're greater than 2 or 3 centimeters in size. So some patients, the first thing that they do after, or they come to me with an ultrasound, or they get their ultrasound, they have this finding. The first treatment is to take that cyst out. And you don't want to wait for years and years and years, because it's not going to go away, and it's going to, generally speaking, continue to get stimulation and could potentially continue to grow or cause scarring. So the sooner you can get it out, the better, and the better you'll feel afterwards. So some people, instead of doing the medication route, will go straight to a surgical route for excision, ablation, and removal of endometriomas or endometrial implants. So you go in with something called laparoscopy, which is like the minimally invasive surgery people may have heard about. It's like little cuts on the belly that we put a camera in and we look around. And if wherever we find the endometriosis, as long as it's safe to remove, we take it out. Or we burn it if we can't take it out, or we sometimes have to call in different types of surgeons, because there can be, like I said, they can be on the bladder or the rectum, and that can make things more difficult because that's not where I usually operate. And part of this inflammatory cycle is that it can also cause scarring. So things can get stuck together, and that can also cause pain. So you want to take away the scarring, you want to take away the endometriomas, those are the cysts, and you want to take away any of the implants that you can see. And people get a lot of relief from surgery. Usually a couple years, sometimes, and I mean a couple, like maybe 2 years, patients do well, but a lot of patients unfortunately need reoperation, especially if there's no treatment to suppress the menstrual cycle after surgery. And that's just like one step in the progress. There's no cure, like I said. So just because we've taken away the current implants that we can see that are safe to take out, you're still at risk for developing new implants. And so calming down the menstrual cycle right after surgery is a good idea if you can do it. So that's one of the two ways I usually start with patients, and sometimes they cross things over, like I was mentioning. So you start with the medications and it's not working, then we try a surgery. And sometimes we do a surgery without any findings on imaging, so that we can see, so we can like look and actually make the diagnosis, like try and find endometriosis to make sure we're doing the right thing, we're not missing something. So you don't need a cyst to go and get this laparoscopy, this evaluation of your abdomen. The ultimate treatment, if everything else has failed, which is what I just did for this lady in her 40s, is a hysterectomy, where you take out the uterus and you take out any other implants that you find. And sometimes you even take out the ovaries, because the ovaries are what's making the hormones and stimulating the implants. And so that's a pretty big decision, if you're
Absolutely.
that when you take out the uterus, this might not be totally obvious to everybody, but once you take the uterus out, like, you can't get pregnant anymore. You don't have periods, which is great, but you've now removed the womb. And so you have to be done with childbearing or not planning to have kids to do that. And sometimes, your hand is forced into that direction because you want to have a good quality of life. And so, that's a decision that you make with your doctor.
Absolutely.
So that's, yeah.
Oh, no, you're fine. Sorry. I can go back.
So that's like the sort of the progression that you can follow for endometriosis.
Absolutely.
And just like I said, it's a spectrum. So some people just need some ibuprofen and they're okay. And some people need multiple surgeries and multiple different medications, and ultimately, a major surgery to be better.
Hysterectomy. Yeah. Would this diagnosis affect my sex life?
So I mentioned the dyspareunia, the fancy word for pain with sex. The good news is that it doesn't happen to everybody. The bad news is that it definitely can happen. And so, yes, it can affect your sex life, because if it's painful to have sex, and when I say sex, I mean penetrative sex. So a penis or a toy or something going into the vagina can be painful, especially if you it's usually in certain spots, and it hurts to have sex. This can be managed. I mentioned we can try doing like the ibuprofen or the birth control pills. And then this new fancy medication I mentioned, Orlissa, is specifically indicated for dyspareunia or painful sex because of endometriosis. And so, yes, it can, but it doesn't have to for you to still have it. But it's something to talk to your doctor about if you're having pain with sex, because you shouldn't.
Got it. So you talked a lot about birth control. Is there any birth control that would not work?
So yes, that's a great question. So I've been talking about hormones, like the birth controls with hormones in them are what we're trying to use, because we're trying to calm down the menstrual cycle. And when I say that, I don't mean like put you in menopause. I think that's an important distinction. I don't mean like make you infertile. I mean, you don't need to have a menstrual cycle every single month to have fertility in the future, because right now it's causing you problems. But there are birth controls that are non-hormonal, which are great options for people, but they don't do anything for endometriosis. So things like the 10-year IUD, it's called Paragard in the US, that is made of copper. And that works actually by inflammation in the uterus to make it an inhospitable environment for a pregnancy. And so I would not recommend patients with endometriosis get that, because you're just sort of adding to the inflammation, and it probably won't be a great option for you. That being said, sometimes that's what works for people. So, it's not an absolute no, but you're not really treating your endometriosis. You're not doing anything about the endometriosis by taking that one. And I mean, endometriosis is not contagious, so you don't have to worry about like passing it on to somebody else. And so that like condoms or something wouldn't do anything for endometriosis. But generally speaking, if there's a hormone in it and it's for birth control, it may help It may not, but it may help with the symptoms.
Got it. Having endometriosis, is it harder to have children?
We know the short answer is it can be. So during C-sections is sometimes when I see endometriosis in patients who don't have the diagnosis. So you definitely can get pregnant because of, despite having endometriosis, it's not something where like you get that diagnosis and that automatically means you're never going to be able to have kids.
Okay.
That being said, we do know that a significant portion of women, people who who have infertility and are trying to get pregnant, end up with a diagnosis of endometriosis as the cause of the infertility. So it's associated with infertility, and there's a couple different explanations. When you have a severe stage disease, meaning not necessarily severe symptoms, because remember, those don't correlate with how much implant and scarring you have in your belly. The severe disease can sometimes actually damage your fallopian tubes because the implants are getting stimulated every month. They are causing inflammation. Inflammation can cause scarring. And so the implants like gradually change from being sort of like these red dots to what we call gunpowder shot dots to like fibrotic lesions. And so they can damage the tubes to the point where the tubes get closed up. And in order to get pregnant, you need an egg from the ovary to pass through the tube, meet a sperm, and then the sperm and the egg join each other and go into the uterus to implant. And so if your tubes are scarred down, you've now blocked that passageway, like a tubal egg. But this is not an intentional one. This is from scarring. Generally, it's pretty uncommon. You have to have really pretty bad endometriosis for your tubes to get that scarred. There is some research that's saying, you know, that goes along with some of the other theories of how endometriosis is started. Instead of saying it's a reflux disease, they're saying there's like it can be spread through the blood or through the lymph nodes or something, and that it can just like spontaneously appear inside the tubes and cause issues for like things to pass through the tubes. That's a little bit less well defined. But we know that it makes it harder to get pregnant, even if the tubes are normal. And I don't have a great explanation for why, except that I know that it happens. So the best thing to do if you want to get pregnant with endometriosis is to try. And if you've been trying for 6 months to a year and you still haven't been able to get pregnant, you should definitely be talking to your doctor about it. That's actually true for anybody. If you tried to get pregnant, having sex at least twice a week for a year and you haven't gotten pregnant, you should see your doctor about that. Because they can do things, you know, we can do some evaluations to help and check out and see what's going on. So most times for infertility, we don't actually have an answer. Actually, infertility, we don't know why people are infertile. But the endometriosis, like we should look into it. We should do something. On the flip side, like I said, women with endometriosis, they can get pregnant, and becoming pregnant is actually not necessarily a treatment, but it makes your endometriosis sort of quiescent, meaning like because you're pregnant, you're not getting that same stimulation to have a menstrual cycle every month.
Oh,
and
that's very true.
Much pain and discomfort as you would if you weren't pregnant. You know, you have the pain and discomfort of pregnancy, but it is different. So yeah, if you can get pregnant with endometriosis. And so I've had a couple patients think once they get the diagnosis, well, I can't get pregnant, so what do I don't need to protect myself from that. And it's like, yes, you do. Please, if you don't want to get pregnant, please be aware that you are, until proven otherwise, fertile, even with this diagnosis.
Can endometriosis go away on its own?
So I'm going to say yes, but not probably how you think. So it's not going to spontaneously be better, in a year after your diagnosis, usually. With treatment, usually we can get it managed. Generally speaking, endometriosis should no longer be causing you those cyclical symptoms once you go through menopause. We don't think endometrial implants that you've got will regress or go away on their own, but the symptoms that they cause when they're no longer being stimulated should stop. So when you're postmenopausal, and that means you no longer get periods, you no longer menstruate, then your endometriosis should be better. that being said, average age for menopause is like 52. So that's a really long time to wait.
That is a very long time.
Get better. Yeah.
Where can I seek treatment for endometriosis?
So you can actually see your primary care doctor at first, because like I said, the first line treatments are things you can get from your family practice doctor or regular doctor to see if it works. I would say if your ibuprofen and your birth control pills aren't really cutting it for you, go see a gynecologist like myself, or go straight to the gynecologist. There's lots of people who get their primary care through one of us, and that's okay too. Just sort of the helpful thing you can do when you come in is like, know when your pain starts, be aware of it, know, like, do I have pain during sex? Or do I actually just have pain during my period, or is it before? And what are the dates? Like, how long before? Is it all the time? What kind of pain is it? Where is it? Because if you have implants on your bladder, sometimes the pain is from peeing. If you have implants on your, sometimes you have pain with pooping. Even sometimes you can get like actual bleeding with the pooping because the implants inside, and so you're like menstruating into your poop. That's pretty uncommon, but it is possible.
Got it.
So yeah, just know what your symptoms are, and then it's just a step-by-step approach to try and help you feel better. But yeah, any obstetrician gynecologist should be able to at least start you on that journey, or even family practice, just to get in the door.
Thank you. Amanda, do we have any questions from our amazing audience?
Not right now. I think you guys did a wonderful job addressing a lot of common questions.
Okay.
So, and this isn't, all inclusive. Like, even as I'm just sitting here, I'm thinking of like a couple other treatments that there's some other specific kinds of injections you can do short term. There's some people say anti-inflammatory diets are super helpful to their endometriosis if you want to, manage it more naturally. So this is literally like the tip of the iceberg of endometriosis. But I think if you take away anything from this, it's just, you should be able to have a normal life while you're on your period, just having to maybe pay attention to going to the bathroom regularly, change pads or whatever. If you're incapacitated because of a period, that's not normal. And that is sort of like there's a lot of societal pressure to just like push through and be strong, which is fine. But there are treatments, some work better than others. Some work better for one person than another, but it's not something that necessarily you just need to be tough for. And that's sort of been the traditional inclination for most people, leading to these really delayed diagnoses. And the sooner we can get on it, the sooner you can feel better.
Absolutely. Well, I would like to thank everyone for their time, especially my love, Dr. Bridget Buyea and Amanda in the audience. I forgot to mention, my name is Gina Smith, and I am the Community Outreach Coordinator here at Heartland. If you would like to be a patient of Dr. Buyea's, because as you can see, she will give you quality care and can answer some amazing questions and treat all of your needs, you can definitely feel free to call us at 773-751-7800. Also, if you don't have a primary care home, please think about allowing Heartland to be your medical home. And you can also call that phone number to set up an appointment with a provider. So once again, thank you all for your time. And if you have any questions, definitely reach out to us. Bye.
Bye.